So with those welcomes under our belt, let's start our agenda. The first talk today is going to be about frontotemporal degeneration. And I'm the speaker. I'm here at the Department of Neurology at the University of Pennsylvania. So what is neurodegeneration? This is a condition that causes cognitive and social decline relative to adult levels of competence. Alzheimer's disease is by far and away the most common cause of neurodegeneration. Alzheimer's disease, as you know, the major problem is memory difficulty, and there can be other changes as well, and these interfere with daily functioning. And the question that we always are confronted with is, what if it's not Alzheimer's disease? And many of you here have experienced exactly this question. Over 10 million individuals in the United States now have a neurodegenerative condition. Half of those folks have Alzheimer's disease. The remainder include a variety of conditions, and today we're going to be speaking about this red segment down here, frontotemporal lobar degeneration. This is not an insignificant number of individuals in the United States right today. We use lots of letters to talk about and name each of these individual conditions, but in aggregate, it represents a reasonably large proportion of individuals who have a neurodegenerative condition, and is indeed as common as Alzheimer's disease under 65 years of age. So what I'm going to be talking about today is the characteristics of the most common young onset neurodegenerative conditions. These were first described by Arnold Pick, whom you can see here, back in Prague in 1892. I'm going to be mentioning some recent scientific findings that are really very, very exciting because this field is moving forward so rapidly, and we'll be talking about treatment options as well. So, the mean age of onset of FTLD is 57 years of age, which is quite young, and it's exactly the reason why Susan mentioned earlier that we went to the Social Service Administration to get special dispensation for individuals with FTLD. The range of onset is quite broad, from 30 years of age to 82 years of age. And as I mentioned, it's as common as Alzheimer's disease under 65 years of age. Let me just review a little bit of anatomy for you. This is the view of the left hemisphere. Many of you know that there are two sides to the brain, a left hemisphere and a right hemisphere. Each hemisphere is divided into 4 lobes. There is a frontal lobe, which is in blue. Then there's a temporal lobe, which is in green. There's a parietal lobe, which is in yellow, and a purple-colored occipital lobe. And in fact, it's the frontal and temporal regions of the brain that are affected in this condition. This is a view of an MRI scan taken at this level. And if you take the slice at this level, and if you turn the brain towards you, this is what you see. This is the left hemisphere on the right side of the picture, the right hemisphere on the left side of the picture. These gray colored areas represent the brain, and the areas that are black up here represent areas that have suffered from neurodegeneration, have accumulated proteins in the brain. The proteins have made the brain cells in this area get smaller and smaller, and eventually you can see the extra space here where there is not the gray area. This is in an individual with semantic variant primary progressive aphasia. If we take a slice a little bit higher up, this is now through the frontal lobe, and we do the same thing and turn the brain towards you. This is the right side of the picture is the left hemisphere, the left side of the picture is the right hemisphere, and you can see here that the areas here that are the brain are smaller than they ought to be. Certainly smaller than the right side of the brain there. And this is in an individual who has non-fluent agrammatic, effortful speech, primary progressive aphasia. So you can see that it's the frontal and the temporal regions of the brain that are suffering from this condition. The natural history of FTD is on average 85.5 months, but the range is very, very broad. The trajectory of the natural history is not linear, it's curvilinear. So things start off very, very slowly, and people remain in the mild stages for half of the natural history. People become moderately impaired, where they're requiring greater support from their loved ones in the moderate stage that goes on for about a quarter of the overall condition. And then the most severe stages, where individuals are entirely dependent on others for activities of daily living, is in the terminal phases of the condition. There are two major phenotypes that we talk about, two major clinical presentations. One is changes in social comportment, personality, and executive functioning, and this represents about 55% of the individuals that we see here at University of Pennsylvania. The other 45% of the individuals have a form of primary progressive aphasia, and I'll be talking about each of these presentations today. What causes FTLD? You heard Susan mention that there is a strong family history in many of the individuals whom we see here, and indeed in our series, about 30% of individuals have a strong family history, that there's somebody else, a brother, sister, parent, grandparent, uncle, aunt, who has a similar condition as well. And we've been able to identify the nature of this inherited condition in a large proportion of individuals, between 20 and 25%, which is really outstanding. The first gene that was discovered was back in 1998, and this is the gene on chromosome 17 that codes for a protein that's called tau. Tau is the Greek letter tau, and tau is the name of a protein that is in all of our brain cells. And because of this mutation, there's a disorder of tau metabolism. The tau becomes misfolded, and it accumulates in an inappropriate manner in the brain. More recently, in 2006, another mutation was found on chromosome 17. This is the GRN, or granulin mutation, and this is associated with the accumulation of another kind of protein that's called TDP43. These two accounted for a large proportion of individuals who have inherited forms of FTLD. About 2 or 3 months ago, another mutation was described on chromosome 9. And this too is associated with the accumulation of TDP43 protein in the brain cells. Between these three mutations, as Susan mentioned, we now are able to explain the majority of the inherited conditions associated with FTLD, which is very, very important. There are also a number of very infrequent conditions that are associated with FTLD as well. There are still some additional individuals who have a very strong family history where we have not yet identified the basis for the inherited FTLD, and we're certainly trying to figure that out. So let me now describe for you some of the phenotypes that I've mentioned. The first I want to talk about is behavioral variant FTD. These are some of the characteristics of BVFTD. There's poor self-regulation, impulsiveness, behavior can be quite disinhibited, and there can be an impairment in social conduct. So individuals will walk up to strangers on the street and start making comments, will be impulsively attracted to something that they see in a store. None of this is intended to be malicious. There are individuals who love little kids and will walk up to little kids in a stroller, and that kid of a stranger will reach down and pick up the child and start throwing the child up in the air to the horror of the parents. When a stranger comes up and does this, you can imagine that it's really quite disturbing. But this is the behavior, and it's not done with maliciousness. It's done because the individual with FTLD loves little kids. There are other kinds of behaviors that we see as well, including hyperoral behavior, where folks will shovel food into their mouths, and indeed things that are not edible will be put in their mouths. Sometimes behavior can be hypersexual. There can be a change in the kinds of jokes that people say, or making sexual allusions throughout conversation, or reaching inappropriately for individuals. There can be hypervisual behavior, where hypervisual behavior, where people get attracted to small little shiny objects or like to set fires. And sometimes anger can be very explosive without any apparent provocation. People will explode. So these are some of the characteristics of behavioral variant FTD. This is a picture of the anatomy that's associated with this syndrome. These yellow areas in the frontal part of the brain and in the front of the temporal part of the brain represent areas that are atrophic or are smaller than they ought to be, like in the MRI images I showed you earlier. And these blue areas that you can see here at the base of the frontal lobe, down over here, are the areas that are most responsible for these kinds of behaviors. And this is a picture of the white matter projections. Our brains contain 10 billion neurons, and all these neurons have to talk with each other. In order for that to occur, there are projections in the white matter that sends signals from one part of the brain to another part of the brain, and this is an image of some of those white matter disturbances that are responsible for some of the changes in the BVFTD patients. There are other kinds of behaviors that we see as well. Some individuals can be quite rigid and quite obsessive, can engage in ritualistic behavior, a series of things that they have to do in a particular order, and will get very, very upset if they're not able to engage in those behaviors, and that tends to be associated with the temporal part of the brain down over here. And yet there are other kinds of behaviors that are in some sense the exact opposite, where individuals will be quite apathetic, will have difficulty with initiation, will be very unmotivated, and will sit around all day, not able to get up, not able to plan and organize their days at all. These kinds of behaviors can be very, very disruptive as well in their own right. When somebody has to urinate, they will say, I have to urinate, and then just sit there without actually getting up and going to the bathroom. And this is associated with changes in these center parts of the brain in FTD. So this is the spectrum of change that we see in individuals with behavioral variant FTD. And to make matters a little bit more difficult, there's poor insight and limited self-evaluation. So even though individuals are engaging in these behaviors, it's important to remember that these are not willful behavior. These are not things where people are willfully trying to be disruptive. And in fact, folks do not really fully appreciate or understand the disruptive nature of their behaviors because they don't have any insight or any ability to really evaluate themselves because, again, these activities are dependent on these same parts of the brain that are compromised in BVFTD. So here's an example of the kind of study that we do to demonstrate this empirically. We show people a picture. This is me trying to do a repair around the house on the weekend, and the question is, what will happen next? And so we give people 3 choices. You can see my wife up here rescuing me, which is usually what happens. Sometimes I am forced to rescue myself. I'll climb up on the roof, and then there are times when my wife laughs at me, which of course are very rare. And we ask people, what is the most likely outcome? What's the best thing that should happen next? And I think many of you will agree that this picture A up here, where my wife and my son are rescuing me, is the best outcome. But when we look at people's choices, we find that patients with behavioral variant FTD are random in their choices. They only about 40% of the time do they pick the correct answer. They don't really have a good concept of what is the next best thing that should occur. And this is related to the frontal and the anterior temporal parts of the brain that I just showed you a minute ago. There's also limited insight, as I mentioned. And we've given individuals a questionnaire, a survey. and we've given them to the caregiver and to the patient, him or herself, and we've asked them about a variety of behaviors like impulse control, empathy, self-monitoring, and you can see in the blue histograms the individual's ratings of themselves, and in the brown histograms the carer's rating of the same behavior in the individual. And 100 is normal and 0 is very aberrant, and you can see that in each of these cases the individual is rating him or herself as doing pretty well in this domain, but indeed, the caregiver is saying, well, I don't think so. So there's a real discrepancy between these two in all of these areas of functioning. And in fact, we probed 15 domains, and of those, 11 of those domains were the individuals with FTD rated themselves as doing quite well relative to the caregiver's own rating of behavior. So what about symptomatic treatment for these conditions? There are a variety of medications that we can use that we've borrowed from various other areas in medicine to try to help manage some of these behaviors. These include neuroleptic agents that are used by psychiatrists to help regulate some behavior, antidepressants that are also used by psychiatrists to help regulate some behavior, anticonvulsants. Some anticonvulsants are really quite good at helping to even out some of the explosive behaviors, and sometimes we use some stimulants in individuals who are apathetic or having difficulty getting going. These medications are pretty good, but none of them is effective. We've just finished a multi-center trial looking at another medicine called memantine. This involves several hundred people from across the United States. We're waiting to see whether this medicine will end up proving to be efficacious in helping to manage BVFTD. None of these medications can work on their own. We also need behavioral management to help manage some of the behaviors, and we'll be talking about these later this afternoon. This includes a structured environment to help regulate what activities people are getting involved in during the course of the day. A curriculum of activities can be very, very helpful as well, so that the burden of having to make all of the decisions that you and I take for granted, that's no longer a major demand. So we generate a curriculum of activities like in a schoolroom, and we avoid exposure to provocative agents that can set individuals off. So all of these symptomatic treatments and these behavioral management strategies work pretty well in terms of being able to manage things, but are certainly not getting at the heart of the condition. That is, they're not treating the underlying cause of the condition. In BVFTD, we know from our brain donation program that 50% of individuals have an accumulation of the protein tau that I mentioned a minute ago, and the other half of individuals have an accumulation of that protein TDP43. In BVFTD, we can't figure out, there are no specific signs to help us figure out clinically whether somebody has tau or whether somebody has TDP43, so we have to develop other ways to figure this out, and these are called biomarkers. Biomarkers define the underlying pathology during life in a minimally invasive manner. There are a variety of things that we can do to try to help us figure out whether an individual is accumulating tau or accumulating TDP43 in the brain. These are useful for prognosis, that is, being able to figure out what's going to happen over time. It's helpful for understanding the underlying mechanisms of disease. Biomarkers are also helpful for identifying individuals who are going to be candidates for disease-modifying treatments that we'll be talking about later this morning as well. And these biomarkers are important for being able to understand what kind of measure I should be following to see whether individuals are benefiting from these new disease-modifying treatments. Here are some examples. We can use behavioral measures So, for example, when we ask people to copy a complicated figure, we find that individuals who have an accumulation of tau end up being most impaired in this kind of measure compared to individuals with TDP-43 and individuals with Alzheimer's disease. On this graph, the top at 0 is where healthy controls are, and any deviation downward represents some impairment, and this is over time, over a series of months. And you can see that the individuals who we know have tau get worse in this particular task figure copy and get worse over time on this, more so than other individuals. Individuals who have TDP-43 by comparison, they are most impaired on measures of naming. And we can follow this over time and document that individuals with TDP-43 have difficulty with this compared to individuals with tau and individuals with Alzheimer's disease. We can also look at various MRI studies to try to figure out what's causing a problem. This is a study that combines looking at the atrophy in the gray matter and atrophy in the white matter of the brains of individuals with FTD, and you can see that the red areas and the blue areas are mostly accumulated in the frontal and the temporal parts of the brain. And this differs from the image that we see with Alzheimer's disease, where the changes in the brain are affecting other areas. So these kinds of very, very sophisticated MRI studies can provide a great deal of information about the nature of the underlying condition. We can also look at biofluids. We can look at blood tests, and we can look at cerebrospinal fluid. This is a study looking at cerebrospinal fluid that is very, very good at distinguishing between who has FTLD and who has Alzheimer's disease. And using CSF, we're now able to make this distinction with over 90% sensitivity and specificity, which is really extraordinarily accurate. And this is important because many individuals with Alzheimer's disease can mimic the individuals who have FTLD. And we have some recent studies of cerebrospinal fluid that can distinguish between TDP and tau, again, with reasonably good diagnostic accuracy. So we're actually very pleased that we're making important advances. We're able to figure out who has tau, who has TDP-43, and there are going to be treatments that are emerging over the course of the next couple of years where we'll be using these kinds of measures to try to figure out who should be getting which kind of treatment. Now let me talk a little bit about progressive aphasia. These are disorders of language that can emerge over time as well. First, let me talk about semantic variant primary progressive aphasia. This is difficulty with fluent speech that is empty, that doesn't seem to make any sense. And it's empty because there's such profound difficulty with finding the words that people want to use when they're speaking. Have difficulty naming very simple line drawings like this. And in an individual case here, that we first saw this individual, they were performing at 30% accuracy in 2004. Then over the years, you can see that there was subsequent decline in functioning to the point where in 2 years later, they were unable to name virtually any of the pictures that we showed him. There's also difficulty with comprehension. This is not just a disorder of being able to express yourself, but this also is a disorder of comprehension. And we will show people, for example, a word and then have them decide which of these other words down here is most associated with this one. And there's an impairment for words, and we can do the same thing with pictures. And we can show that it's not just something that's specific to words, but infects pictures as well. And this is because the concept underlying things like pyramid is degraded. And here you can see that in 2005, this individual was above chance, which is at 50%, and a year later, this individual was having difficulty both with words and with pictures on this kind of task that I just showed you. This is related to the part of the brain that's called the temporal lobe that you can see here. These areas are become atrophied over time, and this is a view from underneath, showing the problems in the temporal lobe. We can then do a correlation between performance and different parts of the brain, and we know that now that this brown area here is the part of the brain that's particularly important for being able to find the words that people are using when they're speaking. And so this is quite compromised in these individuals who have semantic variant primary progressive aphasia. This is a picture of a brain from our autopsy program, the way that we're able to learn about the individual causes of the semantic variant primary progressive aphasia or behavioral variant FTD is by studying the brains directly. We can look at the brains and we can identify the biochemical abnormalities, and then we can go on and try to find treatments, try to find medications that will block the accumulation of the proteins that we've been talking about. Compared to the brain that I showed you up above, this is the brain of an individual with a semantic variant PPA. And you can see that the temporal lobe is much smaller here compared to up here. And when we look with a microscope at this part of the brain, here you can see the brain, we made a slice through here, and we rotated the brain towards you, and you can see that the temporal lobe down here is quite small. When we look with the microscope, this is the surface of the brain up here. I'm sorry, this pointer's not working well. This is the surface of the brain over here. And when we look in this area here, there's a kind of it's pale. And the reason why it's pale is because this is kind of a scarring tissue that we refer to as gliosis, where the neurons have gotten smaller and smaller and eventually have died. And what takes the place of the neurons is a kind of scarring that we refer to as gliosis. When we look with even a higher powered microscope, in individuals with semantic variant PPA, we see staining in the center of the brain cells and in these threads around the outside of the brain cells, and these are staining for TDP43. And we now know that from our autopsy series that about 85% of individuals with semantic variant PPA have an accumulation of TDP43 in the brain, causing the problem. What can we do about this? There are treatment trials that are being planned to try to block the accumulation of the TDP43. Originally, the TDP43 lives in the nucleus, the center, the command center of a neuron or a brain cell, and helps with repair of transcription and translation, helps in the construction, moving things from DNA to RNA to proteins that do work in our brain. And TDP43 plays an important role there, but what happens in conditions like semantic variant PPA and frontotemporal degeneration, the TDP43 no longer stays in the nucleus of the brain cell, but floats out instead into the rest of the brain cell and in fact out into the tissue around the brain cells. We think that the TDP43 helps out and is involved in controlling an inflammatory process. And by treating this very discrete inflammatory process with anti-inflammatory agents, we can help reduce the damage that the TDP43 is doing by accumulating in the areas of the brain cell where it does not belong. So this is an example of a kind of treatment that's being planned, and we hope that in 2 or 3 years we'll be able to offer this as a treatment trial. Next, I'd like to point out that TDP43, as I mentioned, is also the protein that accumulates in Lou Gehrig's disease, in amyotrophic lateral sclerosis. And there is an overlap between ALS and FTLD. that 60% of individuals with ALS do quite well cognitively, that about a third of individuals with ALS also have some cognitive difficulties, and 12.5% of individuals with ALS also have FTLD. And it's because ALS is caused in 95% of the cases by an accumulation of TDP-43. This is a heat map showing the distribution of TDP-43 in the brains of individuals who have just the ALS motor disorder, and it's affecting the motor part of the brain right there. This is an image of individuals with FTD who have TDP-43, and you can see that it's affecting large parts of the brain, the frontal lobe, the temporal lobe. And this is a heat map showing the distribution of pathology in individuals who have a combination of ALS and FTD. And again, you can see that the entire brain is affected. Now I'd like to turn to another form of progressive aphasia that's called non-fluent agrammatic primary progressive aphasia. I'm speaking at a rate of about 140 words per minute. This is me in this gray histogram here. This is words per minute. And individuals with this form of FTD end up speaking at a rate of about 45 words per minute. That's less than 1 word per second. It's quite slow. The speech doesn't come out that metered, it comes out in bursts, and there are pauses in the speech, but it requires a great deal of patience. And the individuals with this form of progressive aphasia are extraordinarily frustrated for obvious reasons because there's so much difficulty at getting out what they want to say. Now, there are many things that could be causing this kind of difficulty. One is there could be something that's called apraxia of speech, which is a difficulty regulating and coordinating the 31 muscle groups that are important for being able to speak. Another possibility is difficulty with planning and organizing. That has nothing to do with language at all, but something that we refer to as executive functioning, where we have to have a sense of what we want to say, and we have to plan out how we say it. That's a general purpose kind of mechanism that we all do in speech and in not speech. And a third possibility has to do with grammar. And that is the ability to plan out specifically what we want to say in language. And it ends up that when we look carefully at what's causing this slowed rate of speech, it really is a deficit in grammatical functioning. This is difficulty being able to put together the words we want to say in a sentence in order to be able to express ourselves clearly and fluently. When we look at the imaging studies of individuals with non-fluent agrammatic primary progressive aphasia, these blue areas of the frontal lobe are the areas that are important for being able to speak fluently, and these green areas here in the inferior frontal lobe and in that is the lower part of the frontal lobe and the upper part of the temporal lobe are the areas that are related to grammatical processing. This is the brain of an individual who has non-fluent agrammatic primary progressive aphasia. This is due to a protein that's called tau, and this area in here is the area where there is atrophy affecting the brain, and that has caused the slowed speech. When we look microscopically, we see several different kinds of tauopathies, that is, several different manifestations of accumulation of the tau protein. We can see here these kind of glassy areas in the brain cells. Then here, these are stained for tau, and these are called Pick bodies. And this was the condition that Arnold Pick first saw in 1892 when he described patients who have Pick's disease. Here you can see another kind of cell that is very, very blown up and enlarged and referred to as balloon cells. And these balloon cells also stain very strongly for tau. And this is what we see in a condition that's called cortical basal degeneration. This is a movement disorder where there are a series of involuntary movements that you'll hear about in a few minutes. And part of the syndrome is difficulty with progressive non-fluent aphasia. Sorry. It's important for me to point out that there are trials for these tauopathies as well. Let me describe for you first what tau does in the brain cells. You can see this is the body of the brain cell that I mentioned previously, and brain cells send these long projections through the white matter to other brain cells, and there are 10 billion neurons in our brain, and they all have to talk with each other, and they do this through these long projections. These red areas here, these are called microtubules. And microtubules send information from the brain cell body here through these long projections to the next brain cell. And these microtubules are kept in place by all these little black dots, and these little black dots are tau. So tau stabilizes microtubules, tau keeps the microtubules in place so that they can do their thing. If tau becomes misfolded, what can happen is that the tau collapses into the center of the brain cells, the microtubules collapse into the center of the brain cells, that clogs up this signaling mechanism, and the brain cells get smaller and smaller, no longer able to function normally. So there are several strategies that have been implemented to try to figure out how to treat this condition, and you'll hear about this later this morning. One strategy is by giving a medication that stabilizes these microtubules even if the tau is no longer in place to do that kind of work. And these are trials that we'll be recruiting individuals for soon. And there's another kind of medication that tries to, that gives a surrogate of tau to individuals, and the surrogate ends up being a target for all of the abnormalities that are occurring to tau, and so will affect the surrogate rather than affecting the tau protein itself. And this will help the tau that's present in the brain cell to survive and to continue to perform its normal function. And this is a trial that we've been using in individuals who have a tauopathy due to a movement disorder. And once this trial is complete, we're hoping to be able to initiate a trial with progressive non-fluent aphasia, with non-fluent agrammatic primary progressive aphasia. So there are symptomatic treatments as well that are available for the progressive aphasias. There are medications that have been tried. Among these are medicines that are borrowed from Parkinson's disease to help out with the fluency of speech, medicines that are borrowed from Alzheimer's disease to help out, again, with the fluency of speech, although I must admit we've not found these to be very effective. And there are also a variety of behavioral strategies that you'll hear more about that we can use to help optimize communication. Among these are speaking slowly, speaking redundantly, saying the same thing using different words, using multiple modalities such as gesture. Individuals with progressive aphasia are quite good at being able to interpret facial expressions. And we can use all of these to help with communication, using simple, grammatically simplified sentences, having small group conversations rather than large groups that can be very, very frustrating for individuals, and developing a personalized picture dictionary to help with word finding difficulties. So our goal is to find effective treatments for frontotemporal degenerations in 10 years. I'm optimistic that we'll be able to do this, but there's a lot of work that we still have to do, and I want to thank all of you in the audience who've helped us with our research program, and all of the other individuals who've worked on these studies with me. It takes, as I mentioned, it's a team sport. Many of these individuals are here helping today who work in our lab, and I want to thank all of these these individuals. Many of you have spoken with Lauren Massimo and with Mariana Deloyan by phone. As I mentioned, the biomarker and the pathology work, our long-time collaborators, John Trojanowski and Virginia Lee, have been wonderful to work with. And I want to thank NIH, Wincote Foundation, other generous friends, families, and individuals with FTD. So thank you. We got started a little bit late, and so we're running a little bit behind. There will be sessions where we'll be able to get together and talk in more details and answer questions, but I'd like to move now to the next speaker, Rachel Gross, who's going to be talking about corticobasal degeneration. So thank you.